Yeah, thank you, Giovanni. It's a pleasure to welcome all of you. Thank you, firstly, for this excellent collaboration. I think we have a very, very interesting topics in our webinar and 3 excellent speakers. And as we have already heard, we start with the 3 presentations, and please send your questions, and we are happy to discuss at the end of this webinar. So my name is Horst Neuhaus from the Evangelische Krankenhaus in Düsseldorf. And it's a great pleasure for me now to introduce the first speaker, Dr. Amyn Haji. He was appointed and is a consultant colorectal and laparoscopic surgeon at the King's College Hospital in London, and he is very experienced in any kind of especially colorectal surgery and laparoscopic interventions, and he has great expertise in endoscopic suturing. And he will talk about a plan for faster patient recovery after ESD. Amyn?
Great, thank you very much, Horst, and thank you to Apollo for arranging this this fantastic meeting. So over the course of the next 10 to 15 minutes, I'd just like to take you through and give you some thoughts about how we can look at functional symptoms post-ESD and aim for a faster recovery. These are my disclosures over the last 3 years. So the overview of this talk is really to give you an idea about what we do for treating complex polyps at King's. We're a tertiary referral centre, and we deal with polyps that are high-risk complex benign polyps, and also a specialist centre for early colorectal cancer. On average, we would conduct between 4 to 6 patients with colorectal ESD every week, and certainly around Europe, this is gaining increasing popularity with more ESD procedures being produced. So our aim is to do en bloc resection with ESD, and 90% of our patients are done under conscious sedation with midazolam and fentanyl, and 10% may require general anesthesia. But recent thoughts are really to focus on how we can make this more efficient, how patients can have faster patient recovery, and how do we reduce complications and readmissions from ESD, and certainly can we offer this as a day case rather than inpatient stay. And the purpose of this talk is really to look at how closing the defects post-ESD can potentially fit into this strategy. There are certain considerations that we need to take if we're looking at closing versus non-closing. Those related to bleeding, to post-ESD electrocoagulation syndrome or PECS, and also the thoughts about delayed perforation, although this is extremely rare in experienced centers for colorectal ESD. With respect to bleeding, this is just some data really that shows that patients who are on anticoagulants, certainly the rate of post-operative bleeding is 13 to 15% in lower GI ESD, much lower than that compared to upper GI. So certainly there's some discussion to be had as to how we need to reduce that rate of bleeding. And one of the problems is that the delayed bleeding trials and the studies that have been out there, whether we close or not with clips or other methods, unfortunately ESD cases are not always included in the data. So there's really some data needed for focusing purely on ESD and closure. With respect to post-ESD electrocoagulation syndrome or PECS, you know that this is related to either fever or an inflammatory response post-ESD, and the incidence is much higher than we think. And certainly we would say in our practice that 1 in 10 of our patients would be getting some degree of PECS post-operatively. And of course there are independent risk factors, but certainly those areas that are resected are large areas or involving more than 50% of the circumference, or patients that have ESD in the proximal colon are at higher risk. And there is some data regarding PECS and closure of defects, and this is quite a busy slide, but just one take-home message, which is that if you look at the incidence of PECS in the group that had closure, and this is using line-assisted clip closure in this particular trial, compared to those patients that did not have closure, you can see that there's a much lower risk of PECs in the patients that do have closure of their defects. And this is some data regarding endoscopic suturing from Sergei Kansovoy's unit, where they actually had a large number of lesions that were resected endoscopically, and they actually looking at an analysis of patients that either had no closure or clip closure or indeed suture closure. And really in the 191 patients that had endoscopic suturing closure, the actual closure of those defects related to no complications in terms of bleeding or delayed perforations. So certainly this is something to think about for your patients that are having this type of day case procedure. So what do we need to consider? The problems are that there is still no general consensus about the need for closing the defect. The literature is often retrospective series and some data on clip closure. And often a lot of the studies do not really consider the functional aspects of patients, in particular what bowel symptoms they have postoperatively, what is their inflammatory response, and is there any confidence regarding earlier discharge for these patients? Are we doing them more as day case rather than 3 to 5 days as inpatient stay? And what we noticed really in our practice, incidentally, was that when you do leave the scar open, we often find patients, particularly after rectal ESD, have increased amount of functional symptoms. And this could be related primarily to urgency and change in bowel habit, leading to diarrhea, associated with some rectal bleeding and fever and occasionally rectal pain. So the closure about ESD, after ESD, in particular for rectal ESD, how do we do it? Well, we currently use the OverStitch SX from Apollo Endosurgery to close these defects, either with a proline suture or with a PDS suture. And often these patients are done under sedation, so we would use a proctoscope initially and then insert the scope through the proctoscope for patient comfort. So this can be done under sedation rather than requiring general anesthesia. And then we would actually look at the actual lesion size and the defect and make a decision regarding the actual suture pattern itself, whether we're going from distal to proximal or proximal to distal, and whether we're doing a running suture and how many sutures that we use. And with time, we felt that actually using more sutures to create a tension-free closure like we would do in surgery often leads to better endoscopic results. So just a couple of videos just to give you an example of how we would actually do this. This is a patient that had rectal ESD, who was a patient who was in his 80s and had a patient who had been on warfarin, and patient had a day case, rectal ESD, under sedation in the endoscopy unit. And here you can see that we're using the endoscopic suturing device. This is by Apollo. This is the SX device. It's mounted at the 7 to 8 o'clock position. And there we are now starting from suturing from the oral side to the anal side. And it's a running suture to meet 50% of the defect. And then after this is placed, we would then cinch the area and close that first area, therefore creating a tension-free closure, and then evaluate the remaining part of the defect with a second suture. Here we found actually using a second suture here often leads to less tension in the wound itself, and also easier closure in terms of dragging the tissue and dragging the suture through the rectal mucosal defect. So here what we would do once again is just using suctioning and torque steering to actually insert the needle, and then we would create some space as we're close to the anal canal, and then the second suture on the anal side using an oral to anal pattern with interrupted sutures, similar to what we would do in closing a wound during open surgery. And this is a final closure, giving you a completely closed rectal defect, and this patient can therefore be discharged home the same day and can recommence as warfarin the next day. Equally, there may be some lesions, and many of you may have patients that have a very low anal rectal lesion coming right down onto the dentate line. and sometimes this can cause a lot of anal pain and urgency and bleeding, particularly post-defecation. So it's often very difficult to close these lesions and close these defects. Certainly we would not be able to use any clips at such a low level. Here you can see that this is the end of the endoscopic submucosal dissection procedure of this very low lesion. And here in this particular area, you can also close the defect even though it's going all the way down to the anal canal. So once again, the suture pattern is such that we would start from the anal side first, from the oral side first, sorry, and then we would go down to the anal side. So the first suture is on the oral side. And then using your scope to come slowly back towards the anal canal, this is coming through the proctoscope itself, we would then make our second suture, which is on the anal side. And this is often extremely challenging if you don't use a proctoscope because it can be uncomfortable for the patient on insertion and coming through. And this is the second suture that you can see. Often at this level, we would use local anesthetic injection prior to the ESD dissection, so patients usually tolerate this very well. Another point to note on very low lesions like this, we would often prefer to use PDS rather than Prolene because then there can be an absorbable nature of the suture and doesn't last for a long time. And here you can see that this is an adequate closure, very low down on the anorectal junction itself. So also able to use the SX in patients that have a very low lesion that needs mucosal closure. So really, in conclusion, I think certainly closing the defect seems to be an easy option when we consider patients that have a lot of comorbidity or patients that need to have day case procedures or traveling very far to a tertiary referral unit, or indeed if they're on anticoagulants. And often we would certainly use this strategy in closing defects for all of these patients. But one thing that we need to consider is certainly in that routine patients that is having a day case ESD, because with respect to functional symptoms, we've certainly noticed an improvement initially in urgency and in diarrhea, and this has led to a much faster patient recovery and potentially an earlier return to work. And we certainly need to explore this, more research into this, in order to see whether there is any value in doing so. Thank you very much for your time, and I hope that many of you will join us at our meeting in November this year.
Okay, thank you very much, Amyn, for this excellent presentation and the very interesting videos. I think this is, of course, a nice approach for a faster recovery, but there will, of course, be some questions which will be discussed later. So thank you for your talk. And now it's a pleasure to ask Professor Bu Hussein Haji. He's a consultant gastroenterologist at King's College Hospital and Chief of Service. And he has also a lot of experience in interventional endoscopy. And today he will talk about shortening of the hospital stay in POEM and GPOEM patients.
Thanks very much indeed, Horst. It's a great pleasure to talk on this lovely evening in London. So my talk today is to examine a slightly different aspect of suturing that we've become aware of. It's the role of suturing for closing the mucosal incision in endoscopic myotomies, both in the esophagus and the stomach. I'm not controlling my slides, so I'll rely on my colleagues to do that. These are my disclosures. We move on. So to first talk about achalasia, I don't want to dwell on the disease itself, but we know that actually it's probably a lot more common than we realized initially, and certainly that's borne out by more recent studies of epidemiology. So the demand for newer and effective treatments is increasing. I think we can say now with some confidence that POEM has been slowly establishing itself as a viable treatment option, not the only treatment option, but certainly one of the options that is available. And we have the benefit of some really excellent studies from our colleagues in Europe, showing that there is a comparison to both pneumatic dilatation and laparoscopic helomyotomy, where POEM is positioned very favorably against the established treatment options. So we performed our first POEM at King's in November 2013. So far, our total cohort is just over 240 patients. And what might be interesting, the reason I include these figures is that I show you that actually a significant number of those patients we performed last year. So there are a couple of things which we implemented, which form part of this discussion, which have allowed us to increase the volume of cases through our unit. Next slide. So the gratuitous photo of me at the feet of Haru Inoue is where we learned our craft. This was in 2010 with I had more hair in 2010, but since 2010 we have followed Haru's protocol for monitoring and discharging patients. In fact, in Japan, the hospital stay is much longer, but the minimum 2-night hospital stay in our practice was our normal practice, keeping the patients nil by mouth for the first night, performing check endoscopy and contrast swallow for all patients on the first postoperative day, allowing liquid diet then on, and discharging the next day if well. Advance, please. And just also to mention, we started performing, when we first performed POEM, all of our procedures were in the theatre, in the surgical theatre. This is one of our particularly lovely theatres at King's in a nice blue light. But we've now moved the majority of the procedures that we do into our endoscopy unit. So when we started, this was a really intensive protocol for our patients with a high admin burden for our staff, arranging tests, arranging the timing, bringing at short notice. One of the real headaches that we have in our service is the cancellation of procedures. I don't know how much of a pressure this is across the world, but certainly in the NHS, bed availability is a premium, and those beds cannot be reserved for patients if there are emergency cases coming into the hospital. So we found ourselves having to sometimes cancel procedures for patients who traveled a long distance to see us on the same day because we didn't have a bed in which to admit them. That bed had been taken by an emergency case. It didn't happen very often, but at least 8 or 10 cases per year on average. So a big headache and frustrating for everyone. Next slide, please. So the first inkling that we perhaps could do things differently came from this paper from Stavropoulos in New York, showing that the OverStitch closure system in esophageal POEM was really comparable both in cost and in procedure time and in safety to the standard mechanisms of closing with endoclips. What wasn't apparent here was any change in hospital stay. But we've been over the last few years, we've been progressively making changes to our follow-up protocol, which will allow us to show you what we've done next. But the main thing that we got from this excellent paper was the idea that they converted to closure using suturing for what was more predictable and secure closure, and that element of safety and reassurance for us was highly important. Next slide, please. So now we've adopted the use of OverStitch for closure. We routinely use it now. For us, and we've been gradually doing this as a step-by-step process, but now we're confident that we achieve a day case procedure. We avoid the 2-night hospital stay. We avoid all the procedures and the checks that we used to have to perform in our previous service iteration. But as I say, this was something that was achieved step by step. We didn't do this overnight. This was done by testing the water and seeing if we could achieve some form of safety and follow-up. But I'm reassured now that we've done that. We've gone through our due diligence. We've done it slowly, but now we've increased our capacity. Next slide, please. So, the way we approached this was just to show you some schematics. Just click through the slides, please. So this is the mucosal defect, and we use a number of, we can use a different number of suture patterns depending on how long the mucosal incision is. Normally, to be honest, in the esophagus, we just use the V-shape suture pattern shown here. This is secure enough because our mucosal incision is quite small. If inadvertently or on purpose you find yourself having to create a longer incision, then perhaps this W shape is more advisable. But either way, this is just a single suture that we're using. That we're now performing this very quickly. Next slide, please. And as I've shown you, I think this has a direct impact on our patient pathway. So we have removed the need to do a contrast swallow on procedure day 1. We've removed the day 1 check OGD. We removed the second night in hospital. Then we removed the first night in hospital. So these were the practice steps that we took as we were starting to implement the suturing into our clinical practice. A gradual process of getting to the point where we are today, where we now aim for routine day case procedures. We also take into account the distance the patient has to travel, and if they had to come back in for a serious adverse event. We do observe patients for several hours after the procedure. We tend to go for more scheduling. But what we found is that significantly reduced the patient burden. We've had no cancellations. Everyone's had their procedure. Everyone's been happy. And we're in the process of working up these results for publication. Next slide, please. So obviously GPOM has come a bit more recently into the field. I hope everyone's aware about the indications. But essentially the principle is the same. We can close the antral mucosa with clips, but this is a challenge. The antral mucosa is thicker than the esophageal. It's under tension. It can invert as you're closing it. Vision can be impaired by the curvature of the stomach, and the handling of the scope can also be impaired. So it's not simple to close securely. And I always find myself, when I was using endoclips, I always find myself being a little bit nervous about whether or not we've achieved complete closure or secure closure. So it felt like a backward step to be doing that. Now we'd established our suturing protocol in the esophagus. So we also said, well, what can we achieve this more easily in the stomach? Next slide, please. So here is a video showing mucosal incision. This is at the end. We're using the OverStitch SX with a Fujifilm 700 series scope. This is a suture pattern possible. We're here in this instance, we're going for the V shape, which is analogous to what we do in the stomach, in the esophagus. Here, what we're showing you here is that with the SX device, you don't need to be very close to the tissue that you're suturing. You can be quite a distance and maintain good vision, or if it's difficult to maneuver the scope very close, you can bring the tissue towards you with the helix, the tissue helix here, which you can see, and then release that once you've placed the suture, so that then drops away and you've placed your first suture very easily. Then the next bite that I'm going to show you is typically what we try and do without the tissue helix if we can, because we have a space that we've already created between the mucosa and the muscle layer. Very gently and safely we can insert the jaws of the helix of the SX device and take a bite to place the second suture, and then place the third and final suture. And what you see here is this was my very first case of suturing with GPOM, and I actually forgot that I was supposed to do it from the pylorus backwards, not the fundus forwards, or the oral side forwards. So, but even so, it's a very straightforward process, very secure closure. And here, showing you one of the tips of the device is to use torque and rotation of the device to bring the tissue well within the jaws of the suturing mechanism to provide a very secure closure. And here you'll see the cinching, which you can watch under direct vision. So it's very reassuring to see the tissue coming together like this, and do this progressively until you're happy, and then release the cinch, release the suture, and there you are. and it's a very secure closure. So we're very happy now that we've closed this. There's no complications here, and the patient can be very, very safe and secure. Next slide, please. So for now, again, we routinely use the OverStitch in our GPOM cases to achieve a reliable and completely headache-free closure for us. I can go to sleep that night being confident that I've closed the mucosa. It's avoided us having to routinely check patients overnight. We can go for earlier discharge. Of course, people with gastroparesis somehow are maybe in a poorer physical condition sometimes, so they still need to have a overnight stay. But what we do is we avoid now the contrast studies, avoiding radiation exposure and the burden for the patient in the hospital. Last slide, please. So just one more slide after this is the cost considerations, just to reassure everyone that actually, obviously, though the OverStitch does cost more in terms of consumables compared to using endoscopic clips, but when we consider the whole service as a whole and doing what it does for us in removing the need for overnight stays, removing the need for post-procedure checks, but what I haven't figured into these graphs here, I've kept them purposely currency-free, but just to show you just for demonstration, but what we haven't figured in here is the cost of a cancellation, not only financial, but also emotional and physical for the patient. And the costs of that will far outweigh any benefits of using a cheaper closure mechanism. Next. So in conclusion, the OverStitch actually has helped us reduce costs. As I mentioned, we've had no on-the-day cancellations like we had before because we're secure that we can discharge patients safely on the same day. It's increased the efficiency of the hospital, so our management is very happy with us. We've removed the administrative burden of doing procedure day case one, post-procedure day one checks. And our patients are more satisfied. They're back to home earlier, there's less examinations and less radiation exposure. I think this is a win-win for everybody. So to conclude,
thank you very much.
Thank you.
This is the end of your very elegant presentation, and your conclusions are quite convincing, but I think again we will have a couple of questions, and also congratulations to the videos. So next talk is done by Rehan Haidry. He is a consultant gastroenterologist and interventional endoscopist, also at the University College in Hospital. And today, Rehan, you will talk about aiming for improved outcomes in fistula management, which is of course a challenge for all interventional endoscopists as well as for surgeons. Rehan? Are you still online?
I think there is a problem of connection, as we cannot see him in the webcam. Let's wait maybe a couple of...
No, he's back. He's back.
Yeah, he's back.
Hi, everyone. Sorry about that.
Okay, Rehan, did I already introduce you?
Thank you very much.
Excellent interventional endoscopist, very experienced, and you are talking about, I think, a very important topic, which is management of fistulas, which is a challenge for all endoscopists, but also for surgeons.
Thank you very much, Horst, and thank you to Apollo for putting together a fantastic webinar, and I've learned a lot from my two predecessors on their lectures. Next slide, please. As Professor Neuhaus mentioned, the gastrointestinal transmural defects are not uncommon and present a big challenge in terms of intervention, whether that is endoscopic or surgical management, and the morbidity to patients from leaks, iatrogenic perforations, or chronic fistulae is not insignificant, and therefore in my opinion, remains a big unmet need in terms of exploring new and innovative techniques to try and improve the outcomes of these patients. Next slide, please. The approaches to what endoscopic intervention is available for these patients, if you can just go through the slide, the animations, depends on the size of the defect, on the exact location in the gastrointestinal tract, but also the chronicity of these defects. If you have more chronic fistulae, these can be more amenable to endoscopic therapy. And it's also very important to understand the anatomy of where these fistulae occur. And often in asymptomatic patients, conservative treatment and medical treatment may be more favorable. And I think the take-home message now, with all of the advance in minimally invasive endoscopic mechanical closure, is most of these defects can be satisfactorily closed with endoscopic approaches. But you know, the message to put across here is that actually these chronic fistulae can be very difficult to treat and often may require re-intervention after re-intervention to get a durable closure. Next slide, please. So when considering an intervention, we need to look really at three areas. One is the effectiveness of any closure technique or device. We need to look at the reliability, but also how diverse and versatile these interventions are, so that we can use them in different GI lumens, but also where the tissue quality can be very, very variable. Next slide, please. So the Apollo device is actually evolved over time from the device which is still in use, which is the double channel device. And as you can see in this video that we'll play here with the SX device, this has provided a little bit more versatility in terms of the fact that you can use scopes that are slightly more ergonomically favorable. And we can access parts of the gastrointestinal tract, as you've seen in the two previous lectures, that historically were very tricky with the slightly bigger double channel scope. So the Apollo OverStitch device is ideal potentially to be an effective, versatile, but also a durable closure device. Next slide, please. So the problem with these chronic fistulae, this is a video that's going to play whilst I talk, if you don't mind, is that in order for the tissue to start to heal through natural processes, you need to disrupt the mucosal surface, and you need to be aggressive. Now, different people have different approaches with cytology brushes. Mine is to use argon at 50 watts and is to really be very aggressive and to completely obliterate that mucosal layer. And then something that Mr. Haji talked about here, you can see this is the generation 2 device, is your first suture, depending on whatever suture pattern that you use to close this defect, should not be a high tension suture, because if this suture comes away, then the defect will not heal completely. So your first suture needs to be a slightly more relaxed suture. Now, depending on the shape and access of your defect, you can choose your suturing style, and I'll talk to you about some of the different variations. Here you can see I'm going to do a sort of figure of 8 suture, and don't be greedy. You know, you want to try and use more than one suture so that you share the pressure points off the suture. And you can see here, as we begin to come to the end of the procedure, once you have cinched the the third suture, you get an effective closure of a chronic fistula after a percutaneous gastrostomy, which has given this patient really a lot of problems. And in fact, this patient needed 2 attempts before they had successful closure. Next slide, please. So you've seen already very elegantly in the previous 2 lectures, how can you suture? Now, when you're closing G-poem or an ESD defect, you often have quite a organized defect where you can plan your suturing. Now, with fistulae, this can be slightly more tricky. This shows some of the different suture techniques, the interrupted suture. I don't favor the running suture because I think you want to try and diversify the pressure points. The figure of 8 suture for me is excellent for the stomach, especially where you have these chronic post-gastrostomy sutures, and the purse string suture with the some of the more the bigger defects where you can sometimes create an ESD type defect is extremely attractive. So if we can go to the next slide, please. The outcomes of fistula closure using endoscopic suturing, they are not big studies on this. They are often case reports. This is probably the biggest study seen. These are 56 patients with fistulae. This was a single session of treatment with the Apollo device. The technical success was good, and the clinical success at 4 months again was attractive at 80%, which I have to say is a lot higher than a lot of the other mechanical therapies. However, you can see, ladies and gentlemen, that the durability at 12 months is poor, is 22.4%. So often these patients will need repeat treatments. And one of the things that we do in our center is we are proactive. We do not wait for them to come back with a leak. We will bring them back in 6 weeks to resuture, to try and reinforce that natural healing, which is what we're trying to promote with this technique. Next slide, please. So if you can just please go through the next 3 animations. This is something that we have now started to do in our center, especially for the gastric defects. And the important point here is to try and create a tissue environment that will heal by natural causes. And so you can see here a very subtle chronic fistula after the insertion of a percutaneous gastrostomy tube. And what one does is create a circumferential incision as if one were doing a submucosal dissection. And once you have released that central tissue, you remove it either with a snare or continuing the incision with a needle knife. And then you, like Mr. Haji showed you in his previous video, you oppose the edges using a running suture and then an overlapping suture. And this is a prospective study that we're currently running in our center. And now to my final video, if we can go to the next slide, please. The problem with fistulae, if you can please play this video, oops, sorry, is that they tend to occur in places that we don't want to go. So this is a patient who had an esophagectomy for a T3 cancer, and you can see that at the anastomosis there is a very large defect, and even I can tell you that that is not part of the gastrointestinal tract. That is the left main bronchus, and you can see the same analogy applies here, that in order for this tissue to heal, you need to disrupt the epithelium, you need to disrupt the mucosa with argon. And then if you can go forward, this is where the SX device is perfect, because you need access, you need versatility, and you can see with the Pentax scope here, the device is mounted on the contralateral side, and you can see that after a series of sutures, the finished product was complete closure of the defect, and an on-table esophagram showed no leak. And although the patient has yet to return for a follow-up, my understanding is that they are well, and you can see in the post at the end of the procedure there is no defect. So in summary, ladies and gentlemen, I think these are quite high-risk procedures. These fistulas should be carried out with surgical backup, and one should intervene early to try and optimize the environment within which the tissue will heal. The size of the defect will ultimately define the closure modality, and endoscopic suturing, as we have seen, is an additional tool that can be leveraged for the treatment of fistulae, is effective, reliable. It may facilitate early patient discharge and reduction in comorbidity. And do not undertreat these patients. Please bring them back and re-suture if you need to, or use mechanical therapy. Thank you very much for your attention.
Yeah, Rehan, thank you very much. Big applause, virtual applause to your presentation. I think you addressed really challenging cases and showed how effectively suturing can be done. We have now about 50 minutes for discussion. We have a couple of questions, but before we go back to the individual presentations, I would like to ask all of you, for those who have now very limited experience with the Apollo suturing system, which are the best cases for the first clinical application? So I assume closure of fistula is quite challenging, but what about, and also management of perforations or bleeding is of course quite stressful because you have to succeed. So it's my impression that closure of an ESD defect is quite attractive for training, and therefore I would like to ask Amyn to discuss this. And what about using it for closure of the mucosotomy for POEM and G-POEM? So what would you recommend? Which are relatively easy cases? You are of course experienced, it looks very impressive, but it may be different for beginners. Maybe Amyn, you can give your comment on the closure of colorectal ESD defects.
Yeah, thanks, Horst. I think a really important point, and similar to, looking for which areas of the colon and rectum are easier to train for ESD, I think this also applies to endoscopic suturing. And what we would recommend are, posterior lesions that are in the upper rectum are easier to access endoscopically, and therefore these are the easiest to suture. So in terms of suturing and getting your skills up, that's what I would recommend. I think in the initial phases, it's often when you're doing this sort of training, it's often easier with propofol sedation or under general anesthetic. But once you get more experienced, this is something that can be performed even under sedation. And if you are going to do under sedation, then the only difficult aspect is insertion of the device through the anal canal. And this is made fairly easy if you insert it through a proctoscope. So my recommendations are try to start with the upper rectal posterior defects.
Is it not more difficult to keep the rectum inflated when you insert the flexible endoscope through a proctoscope?
So you insert the device through the proctoscope, and then you remove the proctoscope and put it over the mid shaft of the endoscope.
Okay.
So when
this is, by the way, the proctoscope is, by the way, also a good trick to remove large specimens, which are difficult to remove just with a net or so. insert the flexible endoscope through a large proctoscope, then it's much easier to resect a specimen. So
Yeah,
we have a couple of questions related to your talk, Amyn, and one is quite important. Is there any concern in case of R1 resection and defect closure in terms of hiding potential recurrences? Of course, you are very experienced and probably comparable to Japanese experts, your R0 resection rate is very, very high. But just in case you have some remaining neoplasia at the margin, and then you close the defect, could this finally cause recurrences which cannot be detected at the follow-up?
I think that's a really, really important point. I think, in my practice, actually, if there's any doubt, and if by any chance you do a hybrid procedure, or there's residual disease, or by any chance you are unable to complete en bloc or do piecemeal resection, I would not advise to close over that defect, because what tends to happen is your initial first surveillance colonoscopy shows normal mucosa, and then you get a much more delayed recurrence. But where you have en bloc resection endoscopically, and you feel that you have good clearance endoscopically, then actually I don't think there's any argument to close the defect. We would then revert to the histology, and if there is cancer that is high risk with R1 resection and with high risk features, then often these patients go on to have either local treatment in terms of chemoradiation, or indeed laparoscopic lymph node harvest. So you would not really have a problem of local recurrence for these patients. It's more systemic failure that's a problem for these patients. I think, as long as you have a good en bloc specimen and you don't feel you've left any residual tissue behind macroscopically, I would say it's safe to close. If there's any doubt about that, then I would be very cautious about closing over some residual disease.
Okay. Another question, how would you explain a reduction in functional symptoms after closing ESD defects? You showed this is your impression, and you showed also data that the PEX syndrome is less frequently seen, but from the physiological standpoint, how to explain that?
Yeah, I mean, I think, we've been, as in colorectal surgery, we've been doing, TEMS and TAMIS for quite some time. And we often noticed that patients would have a lot of urgency when you have a big rectal defect. And I think it's often related to compliance of the rectum. So if you have a lesion with a large area, which is a scar and a big defect, then often the compliance of the rectum is affected. And also there is more intestinal hurry because you have mucosa that's exposed. So I suspect this is why patients have more urgency and diarrhea in those situations. And it's really a hypothesis that these would be reduced. And I think this needs to be subject of further studies, and we're certainly conducting that currently in our practice. The second aspect really is related to fever, because often we know that fever is very common after ESD. And that's often related to bacterial translocation. And the question is, if we irrigate well and then close, we often see potentially a reduction in fever, but that needs to be correlated with some inflammatory markers and regular surveillance of patients afterwards in order to quantify this. So I think it's a combination of factors, particularly for rectal defects.
And would you also close the ESD resection area in the colon? For example, when you do ESD in the ascending colon, this means you have to change the scope, and reinsertion is, of course, time consuming, or do you mainly focus on rectal lesions?
Yeah, I think at the moment we're mainly focusing on rectal lesions. If it's a straight scope and easy access and easy insertion, often that's not the case in Western practice with patients having a lot of diverticular disease and difficult left colon. But I think if it's easy access and high risk, then we would close in the proximal colon. But certainly we are focusing more on rectal lesions currently. But the advantage of the SX is that you can maneuver fairly easily, and therefore you can access the proximal colon.
Okay. Yeah, I completely agree. Also, and you said initially that the rate of delayed perforation is very low when the procedure is done by experts. But I have to admit, sometimes in the rectum, when we treat, for example, patients with recurrences, a lot of fibrosis, then we have to cut quite deeply, close to the muscle layer. We have small perforations, and to close them with clips is challenging. You may even increase the size of the perforation when you cannot catch the edges of the resection, but if you entrap the muscle layer. And I think for these cases in particular, suturing is very advantageous.
Yeah, no, I totally agree, Horst. I think that's a good point, very good point.
Okay, thank you. Then we come to the next topic, poem in G poem. So first question is, when you first started using suturing, did you undertake contrast follows to ensure no leak?
Yeah, that's exactly right. It's a great point, actually, and I hope I'm not suggesting that people should be cavalier about adopting this into their practice. If you're just learning suturing, I think you should do this in a stepwise process and check your closure, as we did with the first 20 or 25 cases that we performed. We always checked more. I think towards the end of that series, more that was for our own psychological benefit rather than for the patient. But as we become confident that we're able to securely close, then we've dispensed with that step now. We don't need that anymore.
Okay, so as a moderator, I have to be a little bit critical, and I think it's very convincing to use it suturing for G poem. I agree, it's sometimes difficult with a thick mucosa to get it in the branches, even if you use large clips. This is quite very useful to proceed to suturing. However, in poem, in most of the cases, we can safely close it with clips. And of course, in your suggested cost benefit advantage by routine suturing, but as you know, there is even a study in 101 patients showing that in 60% of the cases, poem can be done on an outpatient basis without any check, no X-ray, no endoscopy, and therefore, if it's not, of course, we need a control trial to show the cost benefit, what you mentioned. But you select patients in whom you would strongly recommend to suture. Who are the risk candidates for defects after clipping?
Well, for us, the people that we've had that we found challenging are the people who have certainly with type 3 cases, we've had some. We found that very challenging in terms of closure and robust closure or secure closure. With the 101 patients, you're referring to it was the New York and Hopkins, Johns Hopkins study. Yeah, I'm very pleased to see that kind of study. I think it's the studies that we need to establish these kinds of practices. Interesting in that study, some cases were closed with OverStitch, and some were using clips. So I couldn't, from the published data, work out which was which. It would be interesting to know whether there was a difference in those cases. There would be a retrospective analysis, but it would still be interesting. I suspect that if we could make the 62% 90%, then that would be even better.
Yeah. Okay. So I sometimes think it's predictable. It's my personal impression when it gets difficult to close the mucosotomy. In particular, patients with long-standing symptoms with a dilated esophagus, already fibrosis, the initial insertion and incision was difficult. You cannot lift very well. Then we say sometimes the mucosa, it's like a skin of an elephant. It's very difficult it's not flexible, and I think these are the best cases then for suturing.
Sure.
Okay, so then we have a few more minutes for Rehan. Of course, this was very impressive what you showed. There is a question in terms of the aerodigestive fistula. Is there a role for additional stenting to cover the closure? We cannot hear you.
Sorry, Horst. I think that's a
Yes.
really interesting point.
Oh, no, you're back. Okay.
The I'm not a big fan of using covered stents in aero digestive fistulae for two reasons. One is that the migration rate of these stents is not insignificant, because remember, you're putting a stent into a normal caliber esophagus, and so unless you then suture the stent in place, or you use a Novesco stent fix, they tend to migrate. The other thing is that when you use the sutures, especially in the esophagus, you tend to bring the mucosa together, and by putting a stent in, the radial force of the stent can then cause issues with the tension on the sutures. So it's certainly not something I wouldn't advocate. I think one of the things one can do if you have fluoroscopy is to do something as simple as an on-table esophagram with a white tube, and often you can see little leaks. And this is where I think adjunct therapy with either mechanical clips or even an OTC can be very useful in sort of combining modalities to get optimal closure.
Yeah, I think this is a good recommendation to do these procedures under fluoroscopy, and then you can immediately inject contrast to confirm if there is a complete closure or if additional procedures or interventions have to be done. Final question. Let's assume question to you and also to Dr. Haji. A patient had a poem just with clipping, and after 2-3 days suddenly comes back with pain, and you see obviously a leakage or a fistula. So the patient has already an increased CRP, some fever. When it's recommendable to try to close it with suturing, and when to proceed to vacuum therapy with endoscopy, for example, because there may be a risk of access formation when you close the defect. What is your personal approach?
Yeah, well, oh, sorry, go on, Rehan.
Maybe both of you. Yeah.
Yeah, Rehan, please.
We get referred patients quite early on post bariatric surgery, for example, or post esophagectomy, where there is anastomotic leaks. And I think this is where surgeons like Amyn are well placed, because they understand the anatomy of the mediastinum and the peritoneum. Certainly in the mediastinum, if you start to close off defects, as you suggested, you can wall off big collections and cause abscess formation. And so I think this is where a very close discussion with your radiologist and your surgeons about what is the plumbing of these often very closed spaces. And this is where something like vacuum therapy is far superior, because you have access to decrease the size of any inflammatory collection before then using mechanical therapy further down the line when you know that the inflammatory process has subsided.
Dr. Haji, do you agree?
Yeah, I think fortunately in our practice we haven't had any serious complications of POEM like that, but I would agree with Rehan. Yeah, of course. But some of the early cases we had some clips that were dislodged or dehisced. So in some cases we as Rehan says, I think the first priority is to control infection and to limit sepsis. If it's very early after perm and we can prove with imaging that there's no significant collection or significant ongoing leak, then early closure is possible. But by and large, we have to be very careful about that, as Rehan says.
Okay. So unfortunately, gentlemen, time is already over. Thank you very much for your excellent presentation and for the interesting discussion. I think all of us learned a lot. I thank